Hi, this is Dr. Nick with the ECG Academy, and we're going to continue our discussion of interventricular conduction disturbances. In this chapter, I'll cover the types of IVCDs we can diagnose on a rhythm strip. First, a quick review of what we covered in the first chapter. The Purkinje fibers have very rapid conduction, and anything that disturbs the normal Purkinje system activation is going to affect the QRS complex. Widening of the QRS indicates that there's a delay in interventricular conduction, and the generic term for that is an interventricular conduction delay or interventricular conduction disturbance. Now, I showed you what it looks like when you have just a minor problem in your Purkinje system. So what happens is the signal has to kind of slowly make its way through cell-to-cell conduction, which occurs much more slowly than it does through Purkinje fibers. And that delays the signal, and what you get is this kind of weird-looking widening. Now, this QRS complex wasn't over 120 milliseconds in duration. This is only about 110 milliseconds, and we consider this a nonspecific IVCD. We frequently see that as a diagnosis on 12-lead ECGs. In fact, there's going to be a whole section on IVCDs and bundle branch blocks in the intermediate section for those of you who want to be able to recognize this on a 12-lead. But let's see what happens if a larger branch gets affected. For example, when there's delay down the right bundle branch system, let's say the right bundle branch does not get the signal where it needs to go in time. What happens is the left side of the heart activates first, and then you wind up with very slow activation of the right ventricle. Now, the right ventricle is a pretty thin-walled structure, and it doesn't create a lot of voltage, but we can see it on the cardiogram. And often what we see is widening of the QRS complex, but the first part of the QRS complex looks fairly normal. You got a little Q here and a nice tall R, and it's this wide S wave, this negative deflection at the tail end of the QRS complex, that allows you to diagnose a bundle branch block, in this case a right bundle branch block. And we'll get into more detail in the intermediate section, but for the time being, if you notice that the QRS complex has become long, in fact, here it's about 180 milliseconds in duration, and you have this terminal S wave. The beginning looks fairly normal, and then you have this terminal S wave, which is pretty characteristic of a right bundle branch block, because the left ventricle is depolarizing normally, and it's the right ventricle that causes widening of the QRS complex. That's one type of IVCD, and when you see something this wide, it's greater than 120 milliseconds, then we can generally diagnose a bundle branch block this way. Another pretty characteristic bundle branch block pattern is what we refer to as rabbit ears. You can see this QRS goes up, and it's notched at the top. And this is pretty characteristic of a bundle branch block as well. Depending upon what lead we're seeing this in, it can allow us to make the diagnosis of either a left bundle branch block or a right bundle branch block. But I just want you to recognize this pretty characteristic rabbit ear pattern, along with the fact that the QRS here is about 150 to 160 milliseconds in duration. This is a classic example of a bundle branch block pattern with widening of the QRS and the rabbit ears. We can sometimes see this with the right bundle branch block and sometimes a left bundle branch block as well. Okay, so now let's take the example where the left bundle is diseased and that the signal has a hard time getting down the left bundle. With a left bundle branch block, most of the left ventricle doesn't get the signal rapidly, and it can cause very extreme disturbances in the QRS complex. So what usually happens is the signal will go down the right bundle branch and then have to very slowly make its way all around the left ventricle, and you get very bizarre disturbances in the QRS morphology. Often the QRS is extremely long and large, and it looks pretty bizarre. Here you can see the QRS duration is 170 milliseconds or so, and the slope of the electrical signal, often the downslope is very slurred, and that's just a reflection that it's taking a long time to get around the left ventricle. So this widening and this sort of characteristic deep S wave, or sometimes there's no R here, sometimes it's a QS pattern, is pretty characteristic of a left bundle branch block. Now there are a couple of other things that can disturb the electrical signal's ability to get around the heart in a rapid way. Let's say, for example, this patient has complete AV block and they required a permanent pacemaker. Well, what is a pacemaker anyway? A pacemaker is an electrical device that's inserted through a vein, and what happens is there's a wire that's inserted into the right ventricle, and this wire provides the electrical signal that keeps the heart beating. So the electrical signal arises from the tip of the pacing wire, which is generally located in the right ventricle. What happens is this disturbs the electrical activation of the left ventricle. Because the left ventricle has to depolarize very slowly, what you get is a very wide, bizarre electrical signal, a little reminiscent of a left bundle branch block pattern, but this is very wide, here 200 milliseconds in duration. But what you see in the beginning of the QRS complex is a very sharp, narrow signal, and that's known as a pacemaker spike. The spike is the electrical signal that's delivered to the right ventricle, and that's what starts the QRS complex going. So being able to recognize a paced rhythm has a lot to do with seeing the spike, but when the pacemaker is working, the QRS will be very, very wide and bizarre looking, and this is one type of interventricular conduction disturbance, but you wouldn't necessarily call it that. You would basically say this is a paced rhythm. We refer to the QRS complex as being captured by the pacemaker. That's the term that pacemaker specialists use. So this is a captured QRS complex with a pacing spike, and that's why the QRS is so wide. There's one last medical condition that can cause widening of the QRS complex that I'd like to cover in this chapter, and it occurs in patients who were born with a congenital abnormality. They were born with some kind of electrical short circuit that bridges the atrium and the ventricle somewhere on the side where the AV groove runs around and separates the top and bottom chambers. This is kind of like a short circuit that allows the signal to jump across from the atria directly to the ventricles without having to go through the AV node. This short circuit is known as an accessory AV pathway, and because this part of the heart winds up getting the signal earlier than the rest of the heart, the condition is known as pre-excitation, referring to the fact that part of the heart is being excited prematurely. The other name for this condition was named after the three people who first described it, and that's Wolff, Parkinson, White. Now, what you generally see on the cardiogram in Wolff, Parkinson, White is that the QRS complex starts early. Think of it this way. In a normal heartbeat, you have a PR segment, and then the QRS starts, and it's a very sharp upstroke in the QRS complex. In people with pre-excitation, the P wave occurs on time, but because part of the ventricle is excited early, the QRS complex starts early. And because you're not using the Purkinje system, and that conduction occurs very slowly through these cell-to-cell connections, the QRS complex is not sharp in its upstroke, but rather slurred. And so the QRS is generally wider than it should be, and then there are often T-wave abnormalities that go along with it. In essence, what happens is the QRS widens at the expense of the PR interval. So here, this EKG is a typical example of pre-excitation. If you measure back from here, you can see the PR interval is short. It's only maybe 100 milliseconds. The QRS complex is wide. It's just over 120, about 130 milliseconds here. And the upstroke is somewhat slurred. See, it's not a sharp rapid change in voltage over time. It's a very slurred upstroke. This is referred to as a delta wave, and in the advanced course I'll be talking about WPW in great detail. But this is something that you should be able to recognize even on just a rhythm strip, is a short PR, a widened QRS, some STT abnormalities are part of it as well. And the fact that the QRS complex starts very gradually with a sort of a slurring of the upstroke of the QRS complex, and referred to that as a delta wave. A triangle like that is the Greek symbol for the letter delta. By the way, another name for all of these interventricular conduction disturbances is called aberrancy, or aberrant conduction. And I'll talk more about that in the next video. Well, now that we've discussed all different types of IVCDs, in the next chapter I'm going to give you some examples on real ECGs and then discuss the notion of a functional IVCD or a functional bundle branch block, which means that it's not blocked all the time, only under certain circumstances. So for the ECG Academy, this is Dr. Nick. Thanks for watching.